our last sketch, we covered what happens when gallstones form and roll around the biliary system. For round two, we'll take a look at two acute, inflammatory, and oftentimes infectious complications of gallstone disease: acute cholecystitis and acute cholangitis, which is why we find ourselves at this eerily eyes wide shut sort of bocce court. A masquerade themed game complete with costumes, fountains, and a bubble tea bar. First, some rules of the game. The word cholecystitis simply means inflammation of the gallbladder, which most commonly occurs as a result of cystic duct obstruction by a gallstone. Which is why this bocce ball stone has pulled down the gallbladder green tablecloth, inflaming it along the way, if you will. This flame is the key difference between acute cholecystitis and symptomatic cholelithiasis. Whereas both conditions are caused by stones blocking the cystic duct, the prolonged obstruction in acute cholecystitis leads to acute inflammation and all the consequences that come along with it. And speaking of, right upper quadrant pain is characteristic of acute cholecystitis and tends to be more severe and more prolonged than that caused by biliary colic. Sort of the same way being stabbed in the side with a fork is gonna hurt a little more than a tight dog leash. Poor guy. As with biliary colic, acute cholecystitis can be precipitated by a fatty meal. How appropriate then that rich Italian fettuccine was on the menu tonight. Also, as with biliary colic, patients with acute cholecystitis may present with nausea and vomiting, hence the sickly green mask. Unlike biliary colic, however, patients with acute cholecystitis often present with fever, which should tip you off that there's more going on than symptomatic cholelithiasis. To help you remember the fever associated with acute cholecystitis, we've added a flaming headpiece to our party patron here. While most cases are a consequence of gallstone disease, some cases of acute cholecystitis may occur without the presence of gallstones. This is referred to as a calculus cholecystitis. Go figure. Which typically occurs in patients who are already critically ill from something else. Common causes are recent massive surgery, severe trauma, extensive burns, sepsis, or pretty much anything else that can lead to gallbladder stasis and ischemia. This gallbladder stasis and ischemia are the impetus for inflammation. So we've sketched in this ill appearing, unconscious guy who's not moving and seems to have started a fire on this gallbladder tablecloth. No stones necessary. Moving on. Always take into account fever seen on initial vital signs, as this is a key feature suggesting acute cholecystitis rather than biliary colic. As you'd expect, patients with acute cholecystitis often have tenderness to palpation in the right upper quadrant due to local irritation. Additionally, they may also have rebound tenderness or guarding due to parietal peritoneal inflammation. Hence, this guy falling backwards in his chair from that bocce ball rebounding in his face, clutching his right upper quadrant as he guards for impact. The flame pattern on his shirt is there to remind you that peritoneal inflammation is what causes the peritoneal signs of rebound tenderness and guarding. One physical exam finding you'll absolutely come across on wards and exams is Murphy sign, which is pathognomonic for acute cholecystitis. To elicit a Murphy sign, have the patient maximally exhale and apply pressure under the costal margin in the area of the gallbladder. Have them slowly inspire, which forces the gallbladder down towards your awaiting hand. If the gallbladder is acutely inflamed, they will quickly stop inhaling and may even shriek a bit as the inflamed peritoneum comes into contact with your hand, or an ultrasound probe for that matter. To help you remember the Murphy sign, we've sketched this woman suddenly taken aback in pain as his hand is, applied to her side. In many cases, the sign elicited on ultrasound is more accurate as the probe provides a better tool for getting under the costal margin, and since it's performed under visualization, you'll know for sure it's the gallbladder that's irritated. So, physical exam or imaging finding? Little bit of both. Alrighty, this room's getting a little dark a lot of fast. The ominous looking masks here are to remind you of white birds, and more specifically, the elevated white blood cell count you'll often see with acute cholecystitis. Other lab abnormalities, such as elevations in bilirubin, alk-Phos, or GGT, like cholangitis or choledocholithiasis, which fits into the sketchy mantra. The more serious it seems, the less likely it is to just be the gallbladder. Remember that. So, you have what you suspect to be acute cholecystitis. How do you clench the diagnosis and score? As it is with many hepatobiliary conditions, abdominal ultrasound should be the first imaging performed for suspected cholecystitis, which is why we can't have a bocce match without an ultrasound bullhorn. On ultrasound, gallbladder wall thickening is highly suggestive of cholecystitis, especially if the gallbladder wall is more than 4 millimeters thick. Inflammation can also lead to small fluid collections surrounding the gallbladder, known as pericholecystic fluid. To help you remember gallbladder wall thickening on ultrasound, this bullhorn has an extra thick rim. Another thing to be on the lookout for is gas within the gallbladder wall and, to a lesser extent, within the lumen. This is referred to as emphysematous cholecystitis, and it tells you that just got real as the likelihood of gangrene and perforation is instantly higher. But more on that later. For now, just remember that the bubble T within the wall, i.e., on the ledge, may be seen on gallbladder imaging. If the diagnosis of cholecystitis isn't completely confirmed by ultrasound, an additional imaging modality available is cholecintigraphy, aka hide-a-scan, which is why this guy is hiding a stolen clutch of sorts under his coat. Hide-a-scanning involves IV injection of a radiotracer that's excreted by the liver into the bile. Therefore, following injection, you should expect to see it make its way out of the liver, through the common hepatic duct, into the gallbladder, down through the common bile duct, and finally, out into the duodenum. If cholecystitis is present, meaning the cystic duct is obstructed, the gallbladder won't fill with contrast while the rest of the biliary system will. Non visualization of the gallbladder after a certain amount of time is highly suggestive of cholecystitis. To illustrate this concept, notice how the handle of the clutch, representing bile ducts, is glowing radioactive green, while the gallbladder itself, squeezed tightly in his hand, doesn't have the same glimmering glow. Cholecystitis oftentimes doesn't give you too much to work with right off the bat, so it's important to keep in mind other pathologies that can present in the same way. An important part of diagnosing acute cholecystitis is differentiating it from run of the mill biliary colic. The key features indicating acute cholecystitis over biliary colic are fever, leukocytosis, a positive Murphy sign, and gallbladder wall thickening on ultrasound. Choledochal lithiasis may also be present with right upper quadrant pain, but expect to also see jaundice, a cholestatic pattern of lab findings, such as elevated bilirubin, alk-Phos, GGT, AST, and ALT, and common bile duct dilation on abdominal ultrasound. Acute pancreatitis should always be on the DDX of abdominal pain. But with acute pancreatitis, expect to see sharp pain radiating to the back and elevations of serum lipase and amylase to over 3 times the upper limit of normal. Acute liver diseases can cause right upper quadrant pain, nausea, and vomiting as well, but with acute liver diseases, expect to see jaundice, hepatomegaly, and a hepatocellular lab pattern, meaning super high AST and ALT, elevated conjugated bilirubin, and modestly elevated alk-Phos levels. Let's summarize the classic presentation of acute cholecystitis in a sample assessment statement. Sister Coley is a 43-year-old obese woman presenting with severe right upper quadrant pain for the past 12 hours. She's had similar episodes of pain in the past, but they weren't as severe or prolonged as her current episode. Vitals are significant for a temp of 38.8 degrees Celsius and heart rate of 110. Physical exam is significant for right upper quadrant tenderness and positive Murphy sign. Abdominal ultrasound is significant for thickening of the gallbladder wall and pericholecystic fluid. Labs are significant for a white blood cell count of 15,000 with a left shift. Given her exam, lab results, and imaging findings, the most likely diagnosis is acute cholecystitis. Alright, with your diagnosis of acute cholecystitis in hand, it's time to act. First things first, make patients nil per os, aka NPO, aka non potable. This helps with nausea and is a good rule of thumb whenever there's any possibility of having to go to the OR. And the IV? IV fluid should be administered as a resuscitative measure, as supportive care is a staple of treating acute cholecystitis. NSAIDs are a good first measure for pain control as long as there's no contraindications, such as peptic ulcer disease or significant renal impairment. But the majority of patients with acute cholecystitis will require parenteral opioids to get pain under control. To help you remember both, recall this NSAID fire extinguisher and Mutopia masquerade sign. While infection isn't always present, bacterial overgrowth due to acute cholecystitis can spread throughout the gallbladder and biliary system, sometimes even resulting in sepsis. This is why empiric antibiotics are given at least until the gallbladder is out. While the regimen may vary, it's important to cover the top three pathogens associated with cholecystitis and biliary tree infection: E. coli, Enterococcus, and Klebsiella. While supportive therapy with IV fluid resuscitation, pain control, and antibiotics are crucial, source control is even more crucial. That's why patients who are stable enough for surgery, i.e., not in septic shock, should undergo early cholecystectomy, as within 72 hours of admission. To help you remember early cholecystectomy, check out the rising sun on that surgical papaya hat. Before we move on, let's talk a little about the really bad things that can happen in patients with acute cholecystitis. In severe cases, the inflammation in acute cholecystitis can lead to gallbladder ischemia and necrosis, resulting in gangrene. Gangrenous cholecystitis is the most common complication of cholecystitis and is more common in patients with increased age, diabetes, immunosuppression, or late presentation. To help you remember inflammation, ischemia, gangrene, and perforation, the wall of this gallbladder green tablecloth is charred and torn. Local inflammation and perforation of the gallbladder wall can lead to fistulization with surrounding tissues. And what organ is close to the gallbladder and has a lumen perfect for fistulizing with? The duodenum, of course. While cholecystoenteric fistula formation is usually the consequence of long standing, slowly developing pressure necrosis secondary to gallstone disease, it can sometimes develop following acute cholecystitis. And a path obstructed sign on that small intestine looking mat can only mean one thing: small bowel obstruction. If a large enough gallstone passes through a cholecystoenteric fistula, it can cause a mechanical small bowel obstruction, usually at the narrowest portion of the small bowel, the ileum. This is why most cases are referred to as gallstone ileus, even though it's technically a mechanical small bowel obstruction. Remember emphysematous cholecystitis? Well, it's kind of a complication and kind of a primary pathology. Another chicken and egg situation. On the one hand, emphysematous cholecystitis is highly associated with infection by gas forming Clostridium species like Clostridium perfringens. On the other hand, gas in the gallbladder wall can be the result of ischemia and gangrene due to infection by the usual suspects, E. coli or Klebsiella. However, Clostridium is a favorite of question writers. So be sure to make the connection between emphysematous cholecystitis and Clostridium infection. Okay, acute cholecystitis is what happens when the gallbladder gets all inflamed. But what happens when it's the bile ducts that get all hot and bothered? When biliary obstruction and inflammation occur within the major bile ducts, the resultant condition is known as cholangitis. To help you remember infection of the bile ducts, remember this candle tipped over, lighting up the main bocce cord. Pro tip: infection of the biliary tree is often due to bacterial translocation from the intestines, hence the old term ascending cholangitis. Acute cholangitis is associated with three especially important clinical findings, all of which can be seen on this bocce ball banquet bell: fever, hence the flame pattern decorative hat; right upper quadrant pain, as indicated by the pain lines radiating from the CSW, candle shot wound; and jaundice due to biliary obstruction, which can be seen, well, all over. The combination of these three findings is highly associated with acute cholangitis and is referred to as Charcot's triad, hence her short coat emblazoned with a triangle pattern. Keep in mind, however, that only half of patients with acute cholangitis present with all three findings of Charcot's triad. Because, well, not everybody reads the textbook. Womp womp. Acute cholangitis is caused by biliary obstruction. And the most common cause of that obstruction? A stone lodged in the common bile duct, also known as choledocholithiasis. Let this bocce ball gallstone next to Charcot remind you that choledocholithiasis is the most common cause of acute cholangitis. For more details on choledocholithiasis, head on over to our sketch on bile duct disease. Welp, turns out we're not quite done with the eponyms yet. If your patient with acute cholangitis has the findings of Charcot's triad, but in addition develops hypotension, represented by this passed out guy with a blood pressure cuff on his arm, and altered mental status, hence the creepy googly eyes and disheveled brain hat, you've got Raynaud's pentat. So we've tied the fever, right upper quadrant pain, jaundice, hypotension, and altered mental status all here with the pentagon pattern on his vest. Nailed it. Those two additional features of Raynaud's pentad might sound familiar. They're signs of sepsis. Acute suppurative cholangitis is commonly associated with septic shock, represented by this septic sewer lid complete with lightning bolt. Seriously, acute cholangitis is a medical emergency and always should be treated as such. We'll get into that in just a moment. Not surprisingly, leukocytosis is a prominent feature of acute cholangitis. So, more creepy guys in white bird masks throwing a ball onto the main court. Wait your turn, sir. Due to biliary obstruction, acute cholangitis also causes a cholestatic pattern of lab findings, including elevated total and direct bilirubin, hence the yellowish goat mask and his collar like necklace, elevated alkaline phosphatase, represented by the box of ALK chalk, and elevated GGT, represented by our recurring GGT gadget knife. In some cases, acute cholangitis can result in liver abscess formation and hepatocyte injury. This, in turn, causes elevated levels of AST and ALT, shown here with those raised malt glasses. And to help you remember liver abscess, check out that hat. Looks like a liver, but with his angry red mask covering. Remember, acute cholangitis typically does not present with liver abscess or hepatocellular injury. In fact, a lack of hepatocellular injury helps differentiate it from other primary liver pathologies. Your history, physical exam, and a few routine labs should all but cinch the diagnosis of acute cholangitis. When you do suspect acute cholangitis, your next step should be to get some imaging. So, up periscope. The ERCP periscope, that is. ERCP is the imaging and interventional modality of choice for acute cholangitis. ERCP serves two functions. First, like this guy looking through the periscope, ERCP provides direct visualization of the biliary tree, which allows you to diagnose an obstruction. Second, a catheter, like this ball grabber, can be passed through the scope to expand the common bile duct outlet, aka sphincterotomy, and pull out the obstructing stone. But more on that in a moment. If the diagnosis isn't straightforward, say jaundice isn't too bad, there's no fever, the white count isn't super high, or they just don't look that sick, your typical biliary imaging modalities may be performed to help support the diagnosis. This includes abdominal ultrasound, represented by this dude's bullhorn, or MRCP, represented by the magnet he's using to influence the outcome of the game, both of which will visualize dilation of the common bile duct. Well, you're kinda confident that your patient's got acute cholangitis. What else should you be thinking about? Let's take a look at some of the diseases that also classically present with fever and upper abdominal pain, and how acute cholangitis differs from each. The first condition on the differential is what you'd probably expect: acute cholecystitis. Right upper quadrant pain? Check. Fever? Check. However, patients with acute cholecystitis should not have a cholestatic pattern, like significantly elevated bilirubin or ALK phos, on their labs. Additionally, an abdominal ultrasound in acute cholecystitis will show a normal, non dilated common bile duct, while the gallbladder wall will be thickened. Add to that a sonographic Murphy sign, and you've got pretty much all you need to distinguish cholecystitis from cholangitis. Moving slightly further up, you've got to consider liver disease when your patient comes in with a fever and abdominal pain, especially in the right upper quadrant. Some of the acute liver diseases you might have heard about include liver abscesses and portal vein thrombosis. Fortunately, abdominal imaging is often all you need to differentiate acute liver disease from disease affecting the biliary tree. Look for telltale findings on abdominal ultrasound or CT, like a liver mass or occlusion of the portal vein, to point you away from acute cholangitis and more towards liver pathologies. Finally, let's not forget about the pancreas. Patients with acute pancreatitis often present with both fever and abdominal pain. While the pain of pancreatitis is classically epigastric and radiates to the back, it can't be localized to the right upper quadrant in some patients. One distinguishing feature that acute pancreatitis will produce, however, is an elevation in serum lipase and or amylase levels. Look for this on labs to point you towards acute pancreatitis and away from cholangitis. Alright, let's sum up the presentation of acute cholangitis in a sample assessment statement. Angie C. is a 43-year-old obese woman presenting with fever, nausea, and right upper quadrant pain for the past 2 days. Vital exams are significant for a temp of 39.5 degrees Celsius and heart rate of 99. Physical exam is significant for scleral icterus and right upper quadrant tenderness with guarding. Her labs are significant for a white blood cell count of 16,000 with neutrophil predominance, total bilirubin of 8, direct bilirubin of 5, and ALK-Phos of 650. ALT and AST are mildly elevated, while lipase and amylase are within normal limits. Given her lab findings, Angie's presenting symptoms are concerning for acute cholangitis. As we mentioned earlier, acute cholangitis is a medical emergency. Once you make the diagnosis, prompt treatment is required to prevent further badness. As with most conditions in which a sedated procedure might be required, patients with acute cholangitis should be made NPO on admission. Acute cholangitis and septic shock are frequently encountered together, which is why patients with acute cholangitis often require aggressive IV fluid resuscitation. We're talking in the ballpark of 30 milliliters per kilo here. Since acute cholangitis is often associated with septic shock, which often leads to acute kidney injury, IV opioids, rather than NSAIDs, are the first line choice for pain control in these patients. See that curiously petri dish shaped red fountain? That's to remind you that while you're putting your admit orders in, collect some blood cultures. In patients with acute cholangitis, blood cultures help to both diagnose bacteremia and provide useful antibiotic susceptibility data so you can tailor antibiotic therapy. Speaking of which, all patients with acute cholangitis should be started on empiric IV antibiotics, represented by this IV covered antibiotic pill bottle hat that covers the organisms involved in severe intra-abdominal infections. That often means big gun agents like piperacillin and tazobactam, acarbapenem, or cefepime and metronidazole. As we saw previously, ERCP is both diagnostic and therapeutic. Specifically, the endoscopist will perform a sphincterotomy, which dilates the outlet of the common bile duct, extract the obstructing gallstone, and drain all that backed up bile, aka biliary decompression. After the episode of acute cholangitis has resolved, patients with gallstones should undergo cholecystectomy to keep it from happening again. To keep elective cholecystectomy on your mind, we've drawn in this scalpel slice papaya on this partygoer's hat? Headpiece? Whatever that thing is. Notice that it doesn't have a rising sun on it like the hat we drew for acute cholecystitis. This is to remind you that cholecystectomy should only be done after acute cholangitis has resolved. Alright, let's wrap up with a brief recap of what we've learned. Acute cholecystitis is a clinical syndrome of gallbladder inflammation, most commonly caused by gallstone disease. In addition to the classic symptoms of biliary colic, acute cholecystitis is distinguished by the presence of fever. A positive Murphy sign, that is, abrupt catching of the patient's breath on deep inspiration while you palpate the right upper quadrant, is pathognomonic for acute cholecystitis. The only lab abnormality you're likely to see in acute cholecystitis is a leukocytosis with a left shift. Other abnormalities, especially in liver labs like ALT, AST, bilirubin, and ALK-Phos, suggest a different condition as the most likely cause. Abdominal ultrasound is the most common imaging modality used to diagnose acute cholecystitis, with HIDA-scan used if the abdominal ultrasound doesn't cinch the diagnosis. Management of acute cholecystitis includes admitting the patient, making them NPO, giving IV fluids, providing adequate pain control, starting empiric antibiotics, and performing early cholecystectomy within 72 hours of admission. Two special types of cholecystitis deserve a special mention. A calculus cholecystitis, as its name suggests, is not caused by gallstones, but rather gallbladder stasis and ischemia, and typically affects critically ill patients. Emphysematous cholecystitis, on the other hand, is caused by infection of the gallbladder with gas-forming bacteria such as Clostridium perfringens. You'll know it when you see it, because diagnosis involves visualizing gas in the gallbladder wall on imaging. Next up, cholangitis is an inflammatory condition of the bile duct caused by bile stasis and subsequent infection from bacteria ascending from the GI tract. Acute cholangitis typically presents with the clinical syndrome of fever, right upper quadrant pain, and jaundice, aka Charcot's triad. Add on hypotension and altered mental status, and you've got Raynaud's pentad, a marker of severe suprative cholangitis and a true medical emergency. In addition to leukocytosis, a cholestatic lab pattern is often what differentiates patients with acute cholangitis from those with acute cholecystitis. This means elevated conjugated bilirubin, ALK-Phos, and GGT levels. If you see elevated liver transaminases too, that suggests formation of a liver abscess, a bad complication that's associated with a high mortality rate. The imaging modality of choice for acute cholangitis is ERCP, since it's diagnostic and therapeutic. Speaking of therapy, for acute cholangitis, admit the patient and treat them with NPO status, IV fluid resuscitation, pain control, blood cultures, empiric IV antibiotics, and sphincterotomy with stone removal via ERCP. Once the patient has recovered, go ahead and perform a cholecystectomy if the cholangitis was caused by a lodged gallstone. Thanks for watching. In our third and final sketch in this series, we'll dive into some of the less common conditions affecting the bile ducts. They're rare, but that's why test writers love asking about them.